Okay, so thrombotic thrombocytopenia purpura, also known as TTP. Now, this is a hematological emergency with a quite high mortality rate of about 90%, so you should be aware of it. Now, if we try and define the pathology by dividing it into the three words it is divided into, we can appreciate parts of its definition and its pathology. Thrombotic means clot. So there is a platelet microthrombi which is being formed. Thrombocytopenia, as we've previously mentioned, means low platelets, and purpura is one of the clinical features of this, which means skin bleeding. TTP is a clinical syndrome characterized by microangiopathic hemolytic anemia and thrombocytopenia. Now, to understand the pathophysiology of TTP, we need to understand a bit about von Willebrand factor. Now, if you recall, von Willebrand factor is produced from two locations: platelet alpha granules, as well as endothelial cell structures known as viable Palade bodies. Now, if you recall the function of von Willebrand factor, its function in primary hemostasis is to facilitate platelet adhesion and aggregation. So if we have an endothelial line here, so this is the endothelium, and if we have an injury to the endothelium line, von Willebrand factor binds here and allows binding of platelets via their GP1B glycoprotein receptors on the platelets here. Von Willebrand factor is also a carrier protein for factor VIII involved in secondary hemostasis. Now, when von Willebrand factor is produced from its two location, it is produced as a large multimer. So this is a von Willebrand factor large multimer. This large von Willebrand factor multimer isn't really appropriate for circulation, so it is broken down into smaller fragments. So these are smaller fragments of von Willebrand factor, which are more hemostatically active via the ADAM TS13 enzyme. So this enzyme is very important, and the pathophysiology of TTP involves a deficiency, a decrease, or a lack of ADAM TS13. So if there is a lack of this enzyme, you end up with large multimers in circulation. The large von Willebrand factor multimers in circulation rapidly and inappropriately consume platelets, resulting in thrombocytopenia. This also results in aggregation of platelets, which can cause pathological thrombus formation in the microcirculation, resulting in the pentad of TTP symptoms. So what is the cause of a decrease in ADAM TS13? Well, these can be divided into primary and secondary causes. Primary causes are idiopathic and have a genetic underlining. Secondary causes are due to pregnancy, taking the oral contraceptive pill, lupus, and infections. Importantly, drugs can also cause this, especially clopidogrel. Looking at the clinical features of TTP, if we recall, there are microthrombi or pathological microthrombi formation in the microcirculation. Now, if you think of two places or two organs where microcirculation is essential, the two organs that come to mind are the brain and kidney. So you can appreciate that the clinical features of TTP will include the brain and the kidney. The pentad of clinical features initially described include microangiopathic hemolytic anemia, thrombocytopenia or decreased platelets, AKI, neurological abnormalities, as well as a fever. Now we've described why you get renal and neurological symptoms. Now this pentad is important, but it was only the initial description of TTP. Most patients do not present with the entire pentad, and in fact there aren't any pathognomonic features of TTP. Studies have shown that 65% of patients with TTP are female. Studies have also shown a 9-fold relative incidence in black ethnicity compared to non-blacks. Other risk factors include obesity with a BMI of more than 30, as well as pregnancy. In addition, cancer treatments are also a risk factor, in particular mitomycin and cyclosporine. Okay, so if we consider the following investigations, a full blood count would show decreased platelets and decreased hemoglobin, and the decreased hemoglobin here is due to the hemolytic anemia. If we do a coagulation screen, we expect the PT and the APTT both to be normal. And again, this is because TTP is a pathology of primary hemostasis rather than secondary hemostasis. The bleeding time would be increased, the reticulocyte count would be increased, and these are premature red blood cells that are released into circulation from the bone marrow in an attempt to compensate for the anemia. A blood film would show schistocytes, and if you recall, this means split cell. So if you recall, if we have a micro vessel here, we've got a thrombus, we've got a red blood cell attempting to cross through this tight squeeze and is split into two fragments known as schistocytes or helmet cells. The urea and creatinine would both be increased due to the AKI, and the urinalysis would show proteinuria. You may consider doing a direct Coombs test to exclude a differential of autoimmune hemolytic anemia. So treatment of TTP should be done by a hematology specialist. If you encounter a patient presenting with TTP, make sure that you do get in touch with your friendly hematologist. First-line treatments include plasma exchange. You could also use corticosteroids. Second-line treatments includes the use of immunosuppression therapy, including rituximab, vincristine, and cyclosporine. Third-line treatment of TTP is when the pathology is refractory to pharmacological therapy, and in this case you would do a splenectomy. The complications of TTP are related to the formation of microthrombi, and these include acute myocardial infarction, renal dysfunction, and ischemic stroke. Complications of plasma exchange include systemic infection, venous thrombosis, and serum sickness. You can also get complications of long-term corticosteroid use, such as osteoporosis and glucose intolerance.